So good afternoon to everybody. It's really an honor for me and a pleasure to be chairing this third webinar that has been organized by PCR on INOCA, specifically on interventional functional procedure in INOCA. As I said, it's a pleasure for me to be chairing this and honor to be together today with these two experts on the topic, young but really expert that will give us very important insight practically how to do this. Hernan Mejia Renteria from Madrid, Spain, and Carlos Collet from Aalst, Belgium. So the learning objective is going to be to learn the basic principles of combined pressure and flow measurement in the cathlab using dedicated guidewires to understand the differences between the physiological indices obtained with this approach and to become familiarized with methods to measure microvascular resistance. We want this to be interactive, so please give us your question, pose our question, and we will be discussing through the webinars your question, giving you our answers. As you know, as guidelines 2019 give insights and highlight to this kind of procedures, and specifically at as guidelines 2019, it was given a class of recommendation 2A level of evidence B on guidewire-based CFR and microcirculatory resistance measurement that should be considered in patients with persistent symptoms but non-obstructive coronary arteries at coronary angiogram. And more recently, I had again the honor to be co-chairing this EAPCI expert consensus document that was done together with Covadis Group and Microcirculatory Working Group from European Society of Cardiology. In this document that was published last spring in European Heart Journal and simultaneously in Aero Intervention, it was discussing INOCA and specifically what to do in order to diagnose first INOCA, to have a good patient evaluation. You can use non-invasive evaluation on coronary CT angiography, but also, and this was important to highlight in this document, the possibility during invasive coronary angiography to use FCA guidewire and adenosine test, and as a following step, vasoreactivity with acetylcholine test in order to be able to identify INOCA endotype, to identify if there is epicardial vasospastic angina, microvascular angina, or microvascular and epicardial vasospastic angina. When we have the diagnosis of INOCA endotype, clearly we are able then to manage INOCA and to build up a tailored therapy for our patient. And again, this is taken by the expert consensus document. And as you will see, this is the flow chart to be followed during the invasive evaluation. During the coronary angiography, you detect the presence of non-obstructive coronary artery disease. You can do FFR, and then also if FFR is not functional significant, you can go using the guide wires in order to detect the CFR and IMR, and as we said already, according to this value, and this will be discussed in more details by Hernan and Carlos, you will be able to identify the INOCA endotype, and then, as we said, the bottom line to do diagnosis is to give them a tailored approach. And specifically, as I said, in our webinar, we will be discussing the invasive method. And the aim today is to better explain you and try to be simple in our explaining which are the indices that we are going to obtain through this kind of examination, and then Carlos will explain you later on how to practically do this in your CalLab. So please, Hernan is going to discuss first regarding the CFR indices, which is the significance and exactly what are we meaning for that. So please, Hernan.
Thank you very much, Alaide. So in the assessment of INOCA, we should remember that we are looking for disorders at the level of the coronary microcirculation or at the level of the vasomotion. Of course, once we have ruled out obstructive epicardial stenosis. And the components of the coronary microcirculation, different types of arteries and capillaries, are responsible for a specific function and are under the control of the adrenergic system, the own myogenic regulation, and a metabolic control, all of these in order to maintain an adequate oxygen supply according to the myocardial demands. And these functions of the microcirculation have two pathways. One is related directly to the endothelial cells, and this is known as endothelium-dependent function, which is explored, for example, with acetylcholine. And the other pathway is related with the mechanisms in the smooth muscle cells of the coronary vessels, and this is named as non-endothelium-dependent mechanisms, which are explored with adenosine. And following this rationale, it is important to note that the invasive physiological indices like CFR and microvascular resistance indices like IMR and HMR that are measured under hyperemia with adenosine inform, therefore, only on the non-endothelium-dependent mechanisms of the coronary microcirculation. So let's focus on the next slides on the functional assessment of the coronary microcirculation with adenosine. And to achieve an adequate balance between the myocardial demands and blood supply, we need to pay special attention to the arterioles. The arterioles are the main component of the microcirculation and are the responsible of the coronary flow autoregulation. They can modify their size to control the coronary resistance and therefore to regulate the myocardial perfusion pressure in a way that they can maintain a constant coronary flow at rest. However, when there is an increase in the myocardial demands, the arterioles achieve a maximal vasodilation, a condition under which the coronary resistance is minimal, and therefore the coronary flow is maximum. And this is exactly what we are looking for with the CFR index. Starting from the autoregulation of flow under resting condition, we assess the maximal flow obtained under hyperemia with adenosine. And the number of times that a flow increases from rest to hyperemia is the CFR. If this flow increases more than 2 times, we accept that the CFR is normal. But if the flow is not significantly increased under hyperemia, therefore we are talking about a low CFR. And from these basic physiological principles, we can understand what is the coronary flow reserve. The coronary flow reserve is a physiological index that represents the coronary circulation dynamicity and tells us the capacity of the coronary vessels to maintain an adequate balance between the myocardial demands and the oxygen supply. This index is obtained as the ratio between the hyperemic coronary flow and resting coronary flow, and importantly, can be obtained invasively, but also non-invasively using perfusion imaging techniques like CMR and PET. In the case of invasive CFR, we have currently 2 main methods to obtain this index. One is the thermodilution, and the other one is the intracoronary Doppler. So let's see how we can obtain the coronary flow reserve using intracoronary techniques. And this is the thermodilution CFR. This is a method that was developed by De Bruyne and colleagues 2 decades ago following the dilution theory. And the dilution theory says that flow is equal to the vascular volume divided by the mean transit time. And therefore, if the coronary flow reserve is equal to the hyperemic flow divided by the resting flow, and the vascular volume, in this case, the epicardial volume remains constant, then the formula to calculate CFR can be simplified as the mean transit time at rest divided by the mean transit time under hyperemia. And this is how we can see the CFR calculation in the cathlab. This is a screenshot of the physiology console that displays the thermodilution curves that are used to calculate the mean transit time. This is the time that takes the injection of the saline to travel along the coronary vessel under evaluation. And you can see the blue thermodilution curves that correspond to the resting condition, and in orange, the thermodilution curves that correspond to the hyperemic condition. Since the mean transit time is an inverse of the flow, the shorter the mean transit time, the higher the flow. In addition, due to variations in the flow measurement, the standard technique for thermo-CFR requires averaging at least 3 saline injections at rest and averaging at least 3 saline injections on the hyperemia. And I think that Carlos will explain in more detail later how the transit time of the saline is measured with the guidewire. And this is how we can obtain the CFR using intracoronary Doppler. This is a simpler theory compared with the thermodilution, because with this method, we measure directly the coronary flow velocity using intracoronary ultrasound. The physiology console displays the average flow velocity, so we can compare how many times the coronary flow velocity is increased from the rest to the hyperemia. And what is the CFR threshold? This is an important debate about CFR nowadays. And basically, I think that the answer depends on the technique and also the comparator. In the case of the intracoronary techniques, a CFR obtained with thermodilution below 2.0 has been associated with poor prognosis. That, on the other hand, a CFR obtained with intracoronary Doppler below 2.5 has been recently associated with exercise pathophysiology and ischemia according to CMR. And once I that, let's see how we should interpret the CFR result. To interpret this index, it is very important to remember that CFR accounts not only for the coronary microcirculation, but also for the epicardial domain. In other words, CFR is an integral, but not a specific index. For example, in the absence of epicardial significant disease, a low CFR indicates the presence of coronary microvascular dysfunction. But in the presence of obstructive epicardial stenosis, a low CFR is not specifically indicating the presence of microvascular dysfunction, because CFR in this case is being also influenced by the flow limiting stenosis. And therefore, in the assessment of INOCA, we should always combine the interpretation of CFR together with stenosis indices.
Okay, so I think it was quite clear. I mean, my first let's discuss about these. You were showing us the two different methodology, thermodilution and Doppler. Can you go a little bit more into this? What is actually doing? What is your routine? What are you doing routinely in your cathlab? First, and if you want to underline us, which are the main differences.
Okay, thank you, Alex. This is a very good question. I think we should consider that there are differences between these two techniques. Both are very valid to assess the CFR, but there are some differences. For example, the thermodilution technique to obtain CFR, although the theory is more complex, in the practice is more easy compared to the Doppler. You know, to obtain a good Doppler signal with the combo wire, you need a certain level of experience, and you need to be cautious. You need to be very coaxial to the flow. And on the contrary, with the thermodilution wire from Abbott, you have be more confident with some technical aspects like going into the coronary vessel, navigating with this wire, etc. So there are technical differences between both guidewires. I think at the end it depends on the preference of each operator.
But in Madrid, in your cathlab, in the cathlab you're working, what do you use, thermodulation or Doppler? And we ask the same to Carlos, and I will tell what we use in Milano. So
Yeah,
Hernan, you are both.
Yeah, we have both, and we use both.
Okay.
Yeah. At the end, it depends on the, as I said before, on the preference of the operator and experience. Some colleagues feel more comfortable and confident with the thermodilution, and other one with Doppler. At the end, I think that both methods are very valid.
But yes, for example, we should have discussed this later on, but you see, I have a question and I like to be also live in all this discussion. Exactly what I ask. So do you have, if you have a certain patient, which is a criteria, which is set out to have Doppler versus thermo? So in which it's just operator preference to do thermo or Doppler? Do you advise cathlabs to have both, or maybe we can choose one of the two and become familiarized with that and just do that? That I think is, by the way, the best option. But Hernan, so in your cathlab you have both, and apparently this is an operator decision. And what about Carlos? What is in Harst? What do you use?
We see it a little bit different. So from our perspective, the bolus thermodilution technique is extremely easy to use in everyday catheterization. So we preferred most of the time to go for a thermodilution technique. All the interventions are used to it. It's pretty simple to do, as you will see in the next slide. And we reserve Doppler mainly for research purposes. This is what we do in Ulst.
Yeah, exactly the same in Milano. In Milano, we use only thermodilution. We find the methodology very easy to perform, reproducible, and we do that quite routinely nowadays. We have different research projects on the topic, but we become familiarized and we use that. So for us, Milano is thermodilution. That's our practice.
One important topic, Alaide, that Hernan touched upon is the fact that CFR, although is available using bolus thermodilution, you have to do in rest and then in hyperemia, is a non-specific index to assess the microcirculation. Every time that you have epicardial resistance, let's say a lesion in the mid-segment of a coronary, your CFR will be low, and this is because CFR accounts for both the macrovascular and the microvascular compartment. So again, we will move forward and you will see in this webinar with more specific metrics on the microcirculation. But again, CFR is something that includes both components of the coronary microcirculation.
Yeah, very good point. Do you want to answer here, or maybe with the next block of slides you will answer exactly to this question, Hernan?
Yeah, we can move on with the microvascular resistance indices.
Yeah, that's very good. And then we have a lot of questions that are coming, and please keep asking us questions after the next block of Hernan. We will discuss all of your questions, and if it's not anonymous, we will also say your names, which is good. So please, Hernan.
Yeah, thank you. So let's talk about the microvascular resistance indices. So if we think that the vascular compartments of the heart circulation are arranged in series like an electric circuit, then we can apply the Ohm's law to calculate the microvascular resistance as the ratio between the myocardial perfusion pressure and flow. The myocardial perfusion pressure depends on the difference between the distal pressure and the venous pressure, but at the end, venous pressure is negligible compared to the intracoronary distal pressure, and therefore the formula to calculate the microvascular resistance can be simplified, as you can see in this slide, to distal pressure divided by flow. So at the end, to calculate the microvascular resistance, we need simultaneous measurements of pressure and flow. And as we have seen previously, the flow can be estimated with thermodilution or Doppler. And at the same time, the intracoronary distal pressure can be measured directly with a sensor of the same wire. So with the pressure wire X from Abbott and the combo wire from Philips, both guidewires are very useful to measure the microvascular resistance because both physiology wires allow us to obtain simultaneous measurements of pressure and flow. In the case of the thermodilution, remember that the inverse of the mean transit time is a measure of the flow. So the IMR, which is obtained with thermodilution, is the product between the distal pressure and the mean transit time on the hyperemia. And on the contrary, with the intracoronary Doppler, we obtain a direct measure of the flow velocity. And then the HMR, which is obtained with the combo wire, is obtained as the ratio between the distal pressure and the flow velocity under hyperemia. In the case of IMR, it is important to note that the severity of the epicardial stenosis can influence the accuracy of the simple formula. When you are evaluating the microvascular resistance in vessels without stenosis or with mild stenosis, the simple formula of IMR is accurate. On the contrary, in vessels with moderate or severe stenosis, you need to consider the potential effect or the contribution of the collateral flow. The collateral flow increases distal pressure, and therefore, with the simple formula, the IMR can be overestimated. And in this context, the calculation of IMR becomes complex and needs additional parameters like the aortic pressure and the wedge pressure, which this latter is obtained measuring the distal pressure during occlusion of the vessel with balloons. And this is the reason why John and Fearon developed this formula that you can calculate the IMR in the presence of significant stenosis without the need of vessel occlusion by incorporating the aortic pressure and some correction factors. These are two clear examples about the effect of the severity of the epicardial stenosis on IMR. On the top, you can see that the value of IMR doesn't change, is similar between the simple and the corrected formula in the presence of non-obstructive coronary disease with an FFR of 0.9. On the contrary, on the bottom, you can see that in the presence of severe epicardial stenosis, the corrected formula decreases the initial IMR value. And what is the threshold for IMR? So the normal range accepted of IMR is below 25, and this is based on studies reporting a mean IMR value of 19 plus less 5, 2 standard deviations in a healthy population group. And this 25 value is very close to the 75th percentile of IMR found in a large cohort of more than 1,000 patients. So, in summary, the expert consensus on INOCA recently published recommends for the diagnosis of microvascular dysfunction and based on previous studies, the use of CFR less than 2.0 or IMR equal or higher than 25 for the diagnosis of microvascular dysfunction. Let me share with you also this slide because it is very important to highlight that there are fundamental physiological differences between the CFR and the microvascular resistance indices. The CFR, remember, accounts not only for the microvascular domain, but also the epicardial vessels. But on the contrary, the IMR with the corrected formula is a specific index of the microcirculation. And that is the reason why CFR, as you can see in the graphic, decrease as the severity of the epicardial stenosis increases, whereas the IMR is independent of the severity of the epicardial stenosis. So in summary, this is the way we should interpret the invasive assessment of INOCA with the combination of CFR and microvascular resistant indices using adenosine. The presence of low CFR and or a high IMR in the absence of obstructive epicardial disease is indicating the presence of microvascular dysfunction. But on the contrary, a high CFR and a low IMR with a high FFR is indicating the absence of flow-limiting stenosis on one hand, and together with that preserved functionality of the endothelium-independent mechanisms of the microcirculation.
I mean, great. I think it's very clear and give a more widespread also overview of which are the indices that we are able to measure in our cathlab during coronary angiography. So regarding cutoff, I think that the INOCA expert consensus document made some clarification, and thanks to have remember, because there were some discussion on cutoff, but I think, I don't know if you do agree, and I would like to have your opinion on that, which is your opinion on the cutoff that were stated in the expert consensus document. And what do you think? So, Hernan?
Yeah. I think it's a very, very, very good question. As I said before, the threshold for CFR is one of the, matter of debate nowadays. But by fortune, we have this consensus that have come with a clear recommended threshold for CFR, and this is based mainly on the previous studies that has compared the threshold of 2.0 in the case of thermodilution CFR to a poor prognosis at long term. So in my personal opinion, when we are using thermodilution CFR, we should accept this threshold of CFR below 2.0 to consider an abnormal functionality of the microcirculation. And on the other hand, it depends also on the technique and the comparator. We are talking about intracoronary techniques. In the case of the other technique, that is the Doppler, we should move more, to another threshold. In this case, is 2.5. And we have more and more data coming that are showing that when the CFR with Doppler is below 2.0, there are several situations in which you can have an exercise pathophysiology and ischemia when you compare this invasive index with non-invasive index like CMR. So in summary, my personal opinion, this consensus has been very important because has become with a clear recommendation for the use of CFR.
Yes, also because the bottom line is that we want to convince our colleagues that we cannot stop just to non-obstructive coronary artery disease. When we have patients with symptoms and or sign of ischemia stress tests, we need to offer them the possibility to have a true diagnosis. And as we said, giving the true diagnosis with the identification of INOCA endotype, also to give them a tailored therapy. Carlos, any comment on this?
Yeah, from the practical point of view, Alaide, and I think you have touched upon a very important point, is the fact that the patient comes to the cath lab with complaints. It's either because the patient has angina or the patient has a positive non-invasive test showing ischemia. And then we perform coronary angiography and we see 5% of the coronary circulation that might be normal. And I think that is the moment when you have to look at the consensus and say, okay, let's take a pressure wire, let's put down the pressure wire in the LAD, which is the practical approach to see if the microcirculation is diseased. And in about 5-10 minutes, you'll have a full assessment of the complete microcirculation, both by CFR and IMR. And then I think you can provide really either a diagnosis that indeed there is a problem at the level of the microcirculation that we can measure, but we cannot see. But that is reassuring for the patient, and we have tailored therapy for that. We might discuss that further on. But also we can say, yeah, your microcirculation is also normal. So you really have no cardiac origin of your complaints. And that is also reassuring for the patients that come to the cath lab. So I think that is a very important point. And we will see in the next part of the presentation how easy it is to perform these measurements in daily cases in the cath lab.
I absolutely agree. There are a lot of questions that are coming, and I'm very happy. And please give us more questions because we like really to be interactive. So the first is from Ilenia Di Liberto. It's a woman, and apparently that's an Italian name, Italian woman, posing question and giving also the names, which is good. Do you have any experience on the use of thermodilution with a dedicated catheter? So we said that there is the possibility, there is the Doppler, there is the thermodilution. We have to admit that thermodilution is let's not consider CalLab as yours that are expert, university, you do research, but let's consider that we have also to come up with a diagnosis in peripheral CalLabs, because honestly, this is a methodology quite easy to do. It's much easier than any complex PCI. So we advise our colleagues to have this kind of methodology to be able also to give diagnosis. So having said that, apparently thermodilution is a little bit more easy to perform, and Carlos maybe will show us later on. Do you have any specific technology that you are using? So let's start from Hernan, then we ask Carlos, and I can tell what we use in the lab. Hernan?
Yes, I think we are talking about the X-ray catheter. This is a new technology from some years ago, and that has been developed, I think, from the group of the brain, right? So there is some advantage of using this, because you have the opportunity to interchange the wire when you need to continue with an angioplasty. Very, very, very easy. That is one of the main advantages. The other one is that you may avoid the use of adenosine, because you are make an infusion, a continuous infusion of saline using a pump to achieve hyperemia. And this is a way of achieving hyperemia that has demonstrated to be accurate. So you have two advantages that I can say with this new technology. And I think that, in my personal opinion, are very, 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 very good from the practical standpoint.
Okay, then, Carlos, what do you use in your lab?
Well, I think that Erna is referring to the continuous thermodilution method. So everything that we're speaking so far refers to bolus thermodilution, which is the objective of this webinar. We have developed here in ALS also the continuous thermodilution that requires special infusion catheter on top of your pressure wire. And as Hernan mentioned, one, you don't need to use adenosine because the ray flow induces also hyperemia, but the information that we get from the ray flow is absolute coronary flow and absolute coronary resistance, which is completely different from the index that we get from bolus thermodilution, which are indices that reflect the resistance in the microcirculation. So we do believe that this adds a level of accuracy that is not possible with bolus thermodilution, but you require a special material, as Hernan mentioned, a specific catheter to do it.
Okay, so you use, we saw also the publication about the development also of your new technique from ALS. I think is very interesting. However, we do use the same as Hernan, and I think that also a very good thing that we now have in the lab is that the Corventis console that help us also to make this more easier and easy also to capture all the data and also to record these in our patient evaluation. Then I think we have also lots of questions. Let me try to go. They are asking if it's possible to do CFR non-invasively. I think we show these in the introductory slides, but however, I don't think it's the topic specific. Clearly you can do. There are different methodology, but the point here is if you can do during the CalLab activity. So this is a possibility to do non-invasive, but we are discussing specifically if you can do in the CalLab and how to do in the CalLab. So I won't go into this. Another question, how would you define abnormally low IMR? It is clinically important. This is for you, Hernan.
Yes, it's a very, very, very good question.
The name is Roshan. I don't know the name of the person who posed the question.
Okay, yeah. Well, one important aspect about the IMR and the threshold is that we need to consider what is the clinical subset that we are facing. And in this particular webinar, we are talking about INOCA, which is ischemia in the absence of obstructive epicardial stenosis. And for this clinical subset, the accepted threshold for IMR is 25. But if you go to another clinical subset, for example, like the STEMI, when you are measuring IMR after successful PCI of the culprit vessel, the threshold for IMR change. In that case, it will be higher because you are talking about a culprit vessel. In any case, IMR is a physiological index that accounts with a high, very, very, very high solid evidence that support its use to stratify the patients and to determine prognosis, and also to consider what are the adjunctive therapies, like in the case of INOCA patients. So remember, for INOCA patients, we are talking about a threshold of IMR of 20-25, and this is based on studies that have a look to the mean value of IMR when we are investigating healthy group of population.
Okay, thank you. I mean, another question, and then we have to move, I think, to the next block. The other question is anonymous. Do you usually do the testing upfront at the same time while performing an elective coronary procedure, or do you schedule the patient for a later stage microvascular testing? I mean, I can answer for us. Usually, I think it's quite predictable which are the patients that most probably have non-obstructive coronary artery disease, and honestly, we do this at the time of coronary angiography, but this is a Milano perspective. I would like to see, starting with Carlos and then with Hernan, if you can answer quite shortly so we can move to the next, which is your practice. When do you do this assessment?
Yeah, so if we have two scenarios, Aleida. The first scenario is that the patient comes already with, let's say, a CT angiography that shows no epicardial disease. Then if there is a suspicion of microvascular disease, that patient comes directly to the cath lab for full microvascular assessment. We have another scenario that is the patient that is coming with a suspicion of epicardial coronary artery disease, and then we don't find at the moment of the angiography any lesion. And then we have two, let's say, possibilities. Either we perform immediately invasive IMR, either with adenosine or papaverine, or we defer the patient for a second time and we do full microvascular assessment, including not only the non-endothelial dependent pathway, but also acetylcholine testing.
Good. Hernan, which is your practice in Madrid?
Yeah, we prefer to perform this invasive assessment at a stage procedure. And I would say that there are two main reasons. One of them is the important to avoid, to prepare adequately the patient. And in this regard, we should avoid the consumption of caffeine at least 24 hours before the procedure, because otherwise you can blunt the hyperemic response to adenosine, etc. And the other one is that for the full assessment of the microcirculation and the vasomotion disorders, including the acetylcholine test, we prefer to avoid also the vasodilators. So following these reasons, the preparation of the patient is fundamental to obtain a reliable measurement.
So I think at the bottom line, we can say to our audience that if there is a nice possibility that this is a non-obstructive and you have the possibility to stop, for example, vasodilator at least 48 hours before, then maybe you can go directly to do all the evaluation during the coronary angiography. And this is normally what happened to us, where we have also a school, cardiology school, on coronary, on INOCA, and so normally are patients that have been pre-screened or known to have this kind of problem, and they come to us just to do the examination. In all the other cases, clearly you can indeed postpone, because it's important, as it was said, that you have to stop vasodilator before, and you have to have the capability to do the full evaluation. Regarding then the testing with acetylcholine, because we got a lot of questions on that. This is not specifically the topic of this webinar, but clearly this is in further step that you have to do when the indices are not pathological, and you should end also with acetylcholine testing. We are not going too much into this because this is not the object of this third webinar. So Carlos, maybe we can move to the next block where you can show us how easy we can do this kind of examination in the cathlab. So please, Carlos.
Perfect. Let's start by understanding a little bit more what is actually bolus thermodilution. Here you see a vessel, you see a guide wire inside that vessel, and in the bottom of the slide you see a y-axis, and we'll talk about that later. That is an axis of temperature. But let's go back to our vessel that is on the top of the slide. You will see that we have in the pressure wire, actually the pressure wire has a pressure sensor and a temperature sensor. And we have actually two temperature sensors. One temperature sensor is located in the proximal shaft of the wire, and we have a second temperature sensor in the distal part of the wire at the point of the transition of the radiopaque part of the distal part of the pressure wire. Then what happens when we inject saline? And we're going to start, let's say, thinking that these are 3 cc's of saline that comes and pass through this first proximal temperature sensor. So when we are looking at the temperature curve that is in the bottom part of the screen, we will see how these proximal temperature sensors senses the temperature saline in the coronary artery. Of course, the coronary artery is at 37 degrees body temperature. If you inject the saline that is colder, you will induce a decrease in the temperature, and this is how the thermodilution curve looks like. But this saline keeps traveling along the vessel, and it reaches the second sensor, which we call the distal sensor. And when it passes through the distal sensor, this happens. You have the same thermodilution curve, but a little bit later, you will see how there is a deflection of the curve where the temperature actually decreases. And it's the distance between this proximal temperature curve and this distal temperature curve that we're going to measure our mean transit time. And this is what I'm going to show you in the next slides. So to measure CFR and IMR in your cath lab, you need 3 things. One, you need a pressure and a temperature wire, and this is the standard pressure X wire from Abbott. You need a hyperemic agent, you need to induce hyperemia, and you need a dedicated
Okay, so maybe we had some audio problem from Carlos. Maybe in the meantime that they are setting the problem, we can also further with you, Hernan, go in some questions that were coming from the audience. For example, they were asking specifically, and again we do have a name, Prodromos Antopoulos. Positive IMR is confirmatory of CMD. In INOCA, is negative IMR less than 25 enough to exclude CMD? What do you think about this?
Yeah, it's a very, very good question, and I think it's one of the main goals of these webinars. Remember that we are talking about different domains of the microcirculation that are involved in maintaining an adequate balance between the myocardial demands and the oxygen supply. And you have several pathways causing microvascular dysfunction. A high microvascular resistance is just one of them. A high IMR may be caused mainly because of capillary rarefaction, microvascular plugging, or also remodeling of the arteries. But there are also other mechanisms that doesn't work properly in the presence of microvascular dysfunction that are not assessed only with, you cannot rule out only with IMR. You need also the CFR, and you need also the acetylcholine testing. You need to take a look to the endothelial function. You need to take a look to the dynamicity of the coronary circulation to respond to increase in the myocardial demands. So I'm happy to take this question because as I said before, it's very important for the audience to have clear that an isolated IMR less than 25 in INOCA patients should not rule out all of the causes of the microcirculation dysfunction.
Then there was another question, and I think it was interesting because we talk about INOCA, but what about post-PCI, still ischemia and angina with non-obstructive? So should IMR measurement be performed after completion of PCI always, or if they come back with angina post-PCI, but theoretically, I mean, apparently there is non-obstructive coronary artery disease. That's a very important issue and topic, and I think it's something that maybe we can discuss. What is your experience on that? How many times you do this kind of examination in patient post-PCI coming back with angina with non-obstructive coronary artery disease after PCI?
Yeah, it's also a very good question. We don't do it in a routine manner after PCI. But if we have a patient with persistence of angina or recurrence of angina despite a successful PCI, therefore we go for the assessment of the microcirculation using IMR and CFR. By fortune, we have several studies that has demonstrated that pre-PCI IMR more than 27 is a predictor of post-PCI microvascular dysfunction with higher IMR. And also we have other studies that have demonstrated that in patients with persistent angina after a PCI have a high IMR value. So I think it is important to remember that we are talking about INOCA patients, but also in those patients subjected to a PCI and persistent of angina, we also need to take a look into the microcirculation and microcirculatory dysfunction mechanisms.
Okay, so Hernan, you are back. So let's start again your presentation. Okay, that's fine.
Thank you, Laia. This is the things of being live. Huh?
Yeah, that's fine. We manage. With all the questions we got from the audience, very interesting question, we were able to fill the gap. But now we are anxious to hear your lecture.
Very good, very good. So I was discussing the fact that for this, we can use several hyperemic agents. So we have been discussing about adenosine, but actually we can use regadenoson. Here in ALS, we use papaverine. We found that very easy to use inside the cath lab. And you can also use IC adenosine even to do bolus thermodilution. So if we go further here, okay, so one of the important things from the practical point of view, we have seen the importance of understanding the technique in terms of how these bolus of room temperature saline travels to temperature sensors. So you can imagine that if your catheter is not well engaged, you will have not enough saline going to the true sensors. So it's very important that your catheter is well engaged and it's looking coaxial inside your coronary vessel. This will facilitate the water traveling from the first to the second sensor. So the first technical tip is before you start your injections, take a look at your guiding catheter and be sure you are coaxialing the vessel. Then we're going to move forward. Then the second tip, and this you will see different centers doing mainly connecting the saline at the syringe in a different place. This is how we do it in ALS. We use a three-way manifold. The first line is the pressure. In the second line, we have saline. The third line is contrast. And you see that the most important part of this slide is actually showing the 3 cc syringe at the end of the manifold, which is the one that we're going to use to perform the injection for the bolus thermodilution technique. I'm going to show you a video of how we do this in the cath lab. This is a series of educational videos that we have created to teach how to use physiology. I'm joined by Dr. Debrun, and this is the Coroventis machine. So please see that we have changed the setup from the FFR to CFR IMR. This is how the screen looks like. You see there is nothing special in the cath lab. We have just placed the pressure wire distally in the coronary, and we're going to zero the temp. So when we click at this button that is called zero temp, on above your start button, we're actually saying to to the machine to equalize the temperatures between the shaft and the distal temperature. So we're going to perform 3 injections of 3 cc of saline, and look what happened. Look at my hands and look simultaneously what happened in the coroventis. Second injection, and you see clearly the second thermodilution curve, and you see that the first mean transit time is 0.29, the second one is 0.31, and here comes the third one, mean transit time in rest, that is actually 0.21, exactly the same as the first one. So we have performed the evaluation in resting conditions, and now we're going to move to hyperemia. So we induce hyperemia. For this, we have selected IV adenosine in this case. We waited for 2 minutes, and the patient is already hyperemic. So we are ready to start. Before we start, it has happened 2 minutes before the last injection. So I'm going to flush my line to be sure that the saline that is in the line in the catheter is at room temperature to avoid any artifacts in the first injection. And this is what I'm trying to explain there. Bernard is now actually looking at the catheter and making sure that the catheter is coaxial. This is the way you avoid artifacts in your measurement. And when this has been already done, we are ready. So we click on the button of induce hyperemia. We perform the first injection. You see there that the first temperature curve was not so good in terms it was not so deep. We perform a second injection, and now the second injection appears completely different from the first one, and I'm looking at the blue curve that are appearing there in the Coroventis machine, and then I perform a third injection. And look what happened. In this case, there is a yellow box surrounding the mean transit times in hyperemia. This means that the variability of the mean transit time in hyperemia is too high. So we're going to remove the outlier. In this case, is the first time. We do that by clicking on top of the number. And when this has been clicked, it turns red again. I repeat the injection. The mean transit time that was the outlier is replaced by the new injection. And in this case, we obtain a very nice numbers 12, 0.9, and 0.14. And this is an IMR of 9 with a CFR of 2.5. And if we remember what was said by Hernan, this is actually a patient with a normal microcirculation, normal IMR, and normal CFR. So this is case number 1. Before I finish, let me show you how a case with abnormal microcirculation looks like. And we're going to see this case 2, a patient with clear microvascular disease. And you see, again, I'm going to drive you through the screen of the Coroventis to understand a little bit more what we are looking at. When we look at the top, these are the pressure signals. The yellow line on the top of the screen is the FFR. On the bottom, you see the thermodilution curve. The blue curve refers to the curve acquired in resting conditions, while the orange curve refers to the ones acquired in hyperemic condition. If we start looking a little bit more in detail, you will see several things. The first thing we have to do is to place the marker of the PD, in this case the FFR, in a stable tracing, because this is going to be used for the calculation of IMR. This is this value reflected here, 64, and that actually is the value of the green line of the PD curve that is at the level of this yellow line. After we have defined that, we're going to take a look at our resting time. In this case, the mean is 1.18, and the hyperemic is 0.67. Then we are thinking about all the other values which are on the screen, and let me explain you very quickly from where these values come from. The first value, which is CFR, comes from dividing the mean transit time in rest divided by the ones in hyperemia, and this should be your CFR, and your IMR is actually coming from the 0.66, which is your mean transit time in hyperemia, multiplied by your PD, which we saw above is 64. And this is the way you use your Coroventis console to calculate CFR and IMR.
Great. Great, thanks. So just a quick question and quick answer, because we are a little bit unfortunately short of time. So pitfalls, we saw that this is quite quick, very easy to perform. Any tip and tricks, for example, in injection, because sometimes, unfortunately, you have to repeat more than one time regarding the injection. How do you do this? Quite fast, with a continuous force? Anything about that?
So yeah, there are two tips and tricks. One, use the 3cc injection because that will reduce your resistance and will allow you to do a more brisk and fast injection. If your injection is not fast enough, the Coroventis console will give you an error and will tell you repeat the injection and try to do it a little bit faster. But this is something, Alaide, that the learning curve is really fast. I think after you have done 1 or 2, 3 cases, you already understand what is the speed which you have to use to make these injections. And actually, it's pretty simple in the catheterization laboratory.
Okay, anything regarding, for example, if these disconnect, what do you have to do? Because sometimes this can be disconnected, reconnected. Any tip and tricks on this or on other specific?
If by any chance you have to disconnect your Bluetooth device from your pressure wire, the most important thing is don't turn it off. So keep it on, then you can manipulate your wire, whatever you want to do with your wire extra. That will depend on the complexity of the case for the wiring. Then you just clean your wire, make sure that it's dry. You clean it with a dry compress, and then you connect it again, and then you should have the signal back again in your console.
And last question, what if this does not cross? Because clearly it's a good wire, but it's not as good, we have to say, as a BMW or our workhorse wire. What do you do?
Well, in our experience, so we're talking about patients without obstructive epicardial disease. So these are patients actually without really complex coronary artery disease. So the wire usually goes down easily. However, you are right, Alaide, to say that the performance of this wire is not as good as the other wires we use for complex PCI. So I think there are several tips and tricks that you can use. We found that actually in 90 to 95% of the cases when you intend to measure FFR and IMR, you're able to cross with this wire. Some cases you will not be able, but I think it's a minority of the cases.
Okay, in that case, what do you do? Do you use an extension of the wire and then a microcatheter and exchange? That is one possibility, for example.
Well, if you really want to go, let's say you have a lot of tortuosity, that could be an option.
Yeah, you know, angles, tortuosity, something like this, because this is more common in women, and you know, women can have very tortuous vessel, by the way.
Yeah, that can be an option.
Okay, unfortunately, we have only 2 minutes and 40, so I thank a lot Enan and Carlos. And there are a lot of questions, and maybe we can follow these by Twitter, and we'll ask Hernan and Carlos to follow on Twitter, because maybe we can put these on the Twitter and try to answer to all your questions. Thanks a lot, but unfortunately, as always, we are a little bit short of time, so we need to, I think, conclude this third webinar. Again, thanks to Carlos and Hernan. So in conclusion, interventional diagnostic procedure, IDP, can be safely and rapidly done in our CALAB, as it was shown by Carlos during clinically indicated coronary angiography, or we have learned we can plan these in a second time. IDP consists of a diagnostic guide wire pressure and flow measurements and pharmacological coronary reactivity testing. IDP allows to diagnose INOCA endotype, vasospastic angina, microvascular angina, non-cardiac pain, which was underlined before, and I think that's very important, because if the patient have non-cardiac pain at the end, it can be followed by other specialists, and give to this patient a tailored approach, because at the end we want to give a diagnosis, because we want to give a tailored approach and a therapy to this patient, avoiding them to be back and forward to hospital or to cardiologist with a very poor quality of life as this patient have without a diagnosis and a therapy. So we have said this is the third webinar, and we have to thank PCR for this effort they did to have all these webinars on this very important topic. So the next on February 16 is on microcirculatory remodeling as cause of INOCA. Then on March 4th, vasomotor disorders in the epicardial vessel or the microcirculation. March 23, stratified treatment of INOCA Again, important diagnosis, but we have a therapy. So from the cathlab to the outpatient clinic, and the last on April 20, INOCA in specific scenarios. And you can follow the PCR webinars on the link. And again, I would like to thank Carlos, Hernan, and all the PCR team to have made this possible. And let's try to answer to your question by Twitter. So thanks and see you soon, I hope.
Thank you.